that you couldn't even get into this study unless both you, as the provider, and the patient believed the patient would get better with TPA. Unbelievably, they made it an inclusion criteria into their study that if you weren't susceptible to placebo, you're out, which is phenomenally amazing. You can't do that in an unblinded trial. Okay, you just can't. It's crazy. And then they made no effort to blind it on the vast majority. And you'd say, well, what does that matter? I mean, surely people just get better, right? And like no one's going to fudge whether they're a Oxford 2 versus a 3. Well, it turns out the way that their primary outcome was structured was you would literally ask the patient, do you feel like you're better? That's literally their primary outcome. They would call them or send them letters and ask them to say how well they're doing. So if you're in an unblinded study, and to get into that study, you had to say, I believe that TPA works, which is essentially what they had there. And then they ask you later, as their new primary endpoint is, do you feel like you got better? Well, I sure hope so. Otherwise, you didn't belong in the study. Like it's crazy. And that's how they ran it, okay? So they changed the hypothesis, okay? And they never reported the original. They would not report the original. It's still unavailable. We have no idea because you can't get access to the full data set on this. So a guy like me, even if I had a really weird weekend and a lot of beer to like crank through these numbers and generate the study as it should have been done, can't do it because I don't have the data, okay? And then on top of that, it's got some really quirky things. It used to be that the standard response to why was that study negative, they say, you know what? It's them old people. That's what's getting us. And I agree with you. You shouldn't trust old people, okay? But the thing is, they had the most benefit of any group. And I won't trust myself. So that was the standard response. If you go back through the years before this trial was done, every time they're like, oh, why didn't ECAS-1 work out? They're like, it's them old people. They did terribly with their drug. And I was like, you're right. And so did the people that were young. But the problem here is that they did phenomenal in IST3. It turns out that group had as good, if not slightly better benefit than the young folks. So their prior arguments of why do we have like 8 negative studies, why was that? It completely falls apart because they just shot themselves in the foot. Additionally, they had a really bizarre set of time frames when this works. So if you got lytics between 0 and 3 through their incredibly flawed math, you had a good outcome. If you got your lytics between 4.5 hours and 6 hours, you had a good outcome. But if you got it between 3 and 4.5, you actually trended towards harm to where it was nearly statistically significant that you were harmed by lytics between 3 and 4.5 hours. I just said that despite its flaws, the ECAS study actually showed that was the group that they were looking at. So the best study that they have is between 3 and 4.5 hours. This one nearly statistically proved, even with all its flawed methodologies, that that was the group of people that were harmed. It doesn't make any sense. If this drug works, it should have a direct gradient of time to benefit. They have a robust set of literature for this for heart attacks, okay? If you get lytics at 30 minutes compared to 60, compared to 90, compared to 120, you do better the earlier you get. So you really shouldn't wait if you're ever in a community place and you're debating whether to push lytics for a STEMI. You give it as soon as possible. And we don't see it. The data is not there that shows that, 3 hours is actually better than 4 hours, is better than 5 hours. There's not that trend, which means that we don't understand what we're doing. All right, so we'll just call it a draw. So then it raises the question of efficacy versus effectiveness, which are way too similar words for two very different things. So efficacy is, does it work when it works perfectly? Okay, so if I was doing an ultrasound study looking for DVTs and I said, Rich Gordon and Matt Lyon are going to be the folks doing it, that's an efficacy thing. Like, could a superhuman ultrasonographer produce good results from DVT ultrasounds? Which the answer is yes. Then you have to look at effectiveness, okay? So do they teach a very flawed person like myself who's not that great at ultrasound how to do a DVT scan? Am I actually any good at it, or am I terrible compared to the experts, okay? This matters a lot because strokes are tricky. If you poll a bunch of folks, it's really, really hard to definitively say, like, that guy's having a stroke versus is it something else? How often do you call down the neurology folks who love to talk about strokes, and you and them disagree about whether someone's having a stroke, or is it a seizure, or the atypical migraine that apparently is running rampant through Augusta, where like 90% of my neurology patients are having atypical migraines? I don't know. You can't really tell. So they had the Cleveland stroke trial. It's not that Cleveland, though. They actually looked at all the people that got TPA in Cleveland in 1 year, And it is terrifying, okay? Because this was just a community hospital. There's nothing special. These aren't the world experts doing a trial. And it turns out that the mortality in hospitals that use TPA was 16% versus 5% in those that didn't. And what that tells me is that if you're looking at studies where things are perfect, okay, and you've got world experts, and you've got people that read every article on stroke ever, they may be able to make TPA kind of sort of work. At least well enough to where they only had to stop 4 trials because they were killing people as opposed to 8. Okay? But when you actually try it in the community setting where it's just you at 2 a.m. and you get that head CT and it's negative and you're like, I think they're having a stroke, should I push the lytics? Because that's the real world. That's what happens. Okay? Any of you guys that have moonlit know that's the reality of it. Like, would I push lytics here if I didn't have a neurologist on the phone? If it wasn't for really good guys like Hartman Gross using reach carts to make sure that we're not pushing lytics on stuff that we really shouldn't? Like, that's unusual. Very few places have that. And I'm really thankful those guys are there so that we're not doing more harm. Then there's all the stroke mimics. We're running a little bit behind on time, so I'll go through that. Spoiled at an academic center because I have neurologists that can come down. So we're kind of the best case scenario of who could use lytics, and I still don't think it works. So they did a Cochrane review, okay? And this actually shot a lot of the myths down of TPA. They actually show no difference between agents, which is the whole reason why they ignore some of the negative trials that use other agents other than TPA and just focus on the positive TPA ones. But they didn't have any difference based on those, okay? And they also very clearly stated the known increased risk of intracranial hemorrhage, okay? But it ignored the other thrombolytics within that same article, which doesn't make any sense. And they didn't appropriately take into account the fact that the trials that were stopped early weren't included as extra numbers. So we'll continue on for time. So ACEP puts out guidelines about lytics, okay? And there's level A, B, and C evidence. So A, where everyone is believing that something should be done. This is like aspirin for STEMI, okay? You really should be doing this. There's not a lot of debate. If you talk to someone, they're like, I don't know, that whole aspirin for STEMI thing seems overrated. You need to stop listening to them, okay? They just don't know what they're talking about. Level B, where it's like, I think this works, but I can't really prove it. It makes a lot of sense, but there's reasonable people could disagree, okay? And then level C, this is largely like the we just haven't studied it realm, okay? So you get like a good old boy sitting around a table, gobsat kind of recommendations, like me and my buddies think that you should do this. We don't have any data for it. And there are valid things where that's the case. A lot of toxicology literature is that way, because you know what? You're not going to get that 10,000 person randomized cyanide trial anytime soon. No one's getting placebo, all right? You just won't. So it will probably always be that it's just, yeah, I think you should give the drug, and that's fine, okay? So ACEP revised their policy in 2012 after all these studies, all right? So they had a level A in 2012 saying that you should offer to treat ischemic stroke with lytics within 3 hours of onset of symptoms, all right? Just offer it, okay? It actually very wisely didn't say whether you should give it or not, but there should be a discussion of it, okay? And it was basically they ripped the NINS2 data straight from the paper and put it in the guidelines. Okay, it's like if you would have qualified for an NINS2, you get in. And then level B was to consider. Yeah, you don't even have to offer it now. You just have to consider it within 3 to 4.5 hours, and then ripped the ECAS3 guidelines straight in there. So just whatever it was that to get into ECAS3, they just plugged it in with no level C. Okay. And then they very wisely stated that, look, we don't know what's going to happen if you try this in community setting, okay? And that was actually in the guidelines. So it turns out that the deck was stacked there because the number of people with conflicts of interest that were actually writing this is very high. So 4 of the 8 authors had pharmaceutical company conflicts. 3 of them were actually getting money directly from Brigham Ingelheim, the people that make TPA, okay? And authors who actually did research for NINS helped write the outline of the guideline. It was just horrifically stacked as opposed to getting independent folks to do it. So they tried to establish a standard of care. So then ACEP had a lot of folks like me and other people that are really annoying complain about this, saying, look, this is not what we asked. We need you guys to be more clear about what's going on. And they basically wanted to make a revision, okay? So they had an open forum for revision. And I don't know if ACEP's going to do this very often because they were flooded with people that were saying, look, I don't think this works, okay? A lot of the thought leaders in academic emergency medicine are doubters of TPA, a lot of them, okay? And so they had an open forum for revision and people wrote in. I wrote in. I hope some other people in this room wrote in about saying what what we believed. So the only level A was that there was a known risk of intracranial hemorrhage. In almost every study, except for ECAS-3, weirdly enough, there was about a 7% risk of brain bleeds with TPA. And about half the people that got a brain bleed die. Okay? So you got to pretty much, you push the plunger, it's like a known 3% kill rate. Okay? Now, some of that group of people will still get better, and so they might do roughly the same later. Okay? But that's a known proven thing that's been shown through thousands of patients, and that was the only level A. Later, this gets changed, okay? But there were no other level A recommendations. Everything else was level B or lower. So they changed it after the open revision, and people got really mad, okay? This is too small to read. I'm going to only zoom in on this box right up here to what happened in the change of the level A recommendations. This happened a couple months ago, okay? So in the 2015 draft, which is what happened after people wrote in like me saying, I'm angry and have enough time to type about clinical policies. And science. And so what happened is the only level A was that it causes bleeds, okay? That was it, okay? Then in 2015, they dropped the level A that it causes bleeds and then changed the IV TPA should be offered and may given from the may be offered that they have in 2012. So they just put a word, and it sounds a little different between you might offer it to you should offer it and you may give it. And then the increased risk should be considered, and that's it. They dropped it from a level A. Now, was there anything that happened in the last few months that would have changed how often people get brain bleeds with TPA? No. There has been no study that has come out since when they opened this up to now that has any impact on this whatsoever. None. They had no new data, and they downgraded the one thing that we're certain of, that everyone that knows what they're talking about would say, that there's a 5 to 7% increased risk of intracranial hemorrhage when you give TPA. It's the only thing everyone in the room could agree with. And they downgraded that bit of thing from a level A to a level B with no reason whatsoever. And then they changed the language from what everyone was saying of saying, you may consider offering it to you should offer it, with completely ignoring, are you at a hospital that has any business giving this drug? Should docs in Barnwell feel like they should be doing this? Does that make any sense? And I would say the Cleveland Stroke Trial and many others like it would say no. Like if you don't have a dedicated stroke neurology team, you got no business giving this. Okay? If you can't get a Hart McGross or someone like him on the phone through a reach cart, you should not be just pushing this willy-nilly. And the American Heart Association is pure evil. Amazingly, their conference headquarters, the headquarters of the AHA, was literally built by Genentech. And so I think that goes a long way towards explaining why on earth the American Heart Association is one of the biggest pushers of TPA for stroke, forgetting the fact that the heart and the brain are two very different organs. It's just really weird. They actually said, they had a press release saying, TPA saves lives. And then someone said, where's the study for that? Because actually it increases mortality but may improve disability, best case scenario. They're like, well, we'll retract that because sorry. It's really funny. So Genentech's pure evil. They're just terrible. So you say like, okay, I hear you, Dan. Like, you don't like TPA. What am I going to do? I got this guy. Like, what are you going to do? Are you just going to give him nothing? Are you going to rub some capsaicin on his forehead? Which might work. Could. Y'all remember the head off commercials? Like, what was it, head on? They just said like head on like 95 times during it. It might work. I don't know. So aspirin is legit, okay? Whenever someone's like, hey, should we give aspirin or not? The answer is yes. I think like GI bleeders should probably get aspirin. I mean, like everybody should get it. Everybody should get aspirin. All right. So they did some studies at Cochrane Reviews. There were 9 studies. Almost all of them were 2 studies. Like 40,000 of those 41,000 and change people were from 2 studies. So you got IST, and then you got CAST. And I'm running out of time. They were positive, okay? So what happens if you just give an aspirin, okay? You don't give anything else. You're just like, you're having a stroke, here's your aspirin, and we'll continue it for a few more weeks. The number needed to treat to save a life is 79. TPA can't say that at all. They have no data showing that they have a mortality benefit. Aspirin does. The number needed to treat is in the 80s for complete recovery. Not, oh, you're a little better. You're all the way better. 89, okay? The number needed to treat just over 100 for all causes of death, not just stroke-related death, but just did you have a heart attack or did you die of a PE or whatever. All got better for aspirin. Why is this so relevant? because it looks so much better than TPA, and it costs nothing. You can buy a lifetime supply of aspirin at Costco for like $3. I mean, every tab of aspirin you could ever